minutes to allow other people to join, and we'll start at 11:05 Eastern Time, 8:05 p.m. Pakistan time. I would request all the attendees and panelists who are not actively speaking or answering questions to please keep their mic on mute. Thank you very much. I think we have a healthy quorum of panelists and attendees today, so I'm going to start again with an introduction to our excellent panel this morning or this evening in Pakistan. I would request our main speaker, Dr. Mehreen Arshad, to introduce herself, and then all the other panelists will introduce themselves, and Dr. Mehreen will start with her presentation. So Dr. Mehreen Arshad, please, would you like to introduce yourself?
I was on mute. So absolutely. Thank you so much for having me present this topic today. My name is Mehreen Arshad, and I am a pediatric infectious disease physician. I graduated from medical school in Pakistan, but then and right now I am faculty at Lurie Children's Hospital at Northwestern University in Chicago.
Thank you, Dr. Mehreen. You're the ideal person to lead this panel. We have also Dr. Asma Jafri. Would you please introduce yourself?
Dr. Asthma, you're muted.
I'm Asma Jaffrey. I graduated from Fatma Jinnah Medical College in Pakistan, and I'm currently chair of Family Medicine Department at University of California School of Medicine, Riverside.
Thank you, Dr. Asma. We also have Mr. Robin Sheikh. Would you please introduce yourself?
Hi, I'm Dr. Robin Sheikh. I did my doctorate at Quinnipiac University in nursing practice and care of populations. I'm the full-time school nurse at Lincoln Sudbury Regional High School in a town near Boston, Massachusetts.
Dr. Sheikh, thank you very much. Sorry, my apologies for mispronouncing your title. I think you're
No problem.
And we also have Dr. Sami Ahmed.
Hello, good morning. Assalamu alaikum. My name is Sami Ahmed. I'm a graduate of Dow Medical College. I trained in pediatrics, pediatric neurology, and sleep medicine at Texas Children's Hospital and Baylor College of Medicine. I'm an assistant professor in pediatrics as a child neurologist at the Children's Hospital of San Antonio and Baylor College of Medicine. Thank you for the invitation.
Thank you very much. And, I'm honored to be hosting this. My name is IQBAL Ahmed, and I'm a pediatric anesthesiologist at Children's Medical Center in Dallas, Texas, and on faculty at the University of Texas. So without further ado, we'll request Dr. Mehreen Arshad to start her presentation. Thank you very much.
All right, thank you. So, all right, so there have been a lot of news about school opening in the last few weeks, and these are just some of the headlines that have come up. There's been thousands of kids that have required quarantining after school opening, and so the question has been, what is successful school opening look like if you send kids to school and then within a couple of weeks you have to quarantine thousands and thousands of kids. You all may have seen this this viral photo that was taken by a student at a high school in Georgia, where they showed packed crowds in a hallway and almost nobody wearing a mask. This school had to close down pretty quickly after that. And then the more recent news that came out of Florida that confirmed that there have been 9,000 new cases of COVID-19 among children within 15 days of school reopening. So the facts that we have to work with right now is that COVID-19 is here to stay for a while. We sort of in the Western part of the world have been tackling with this since March. Other parts of the world have been tackling with this earlier on, but there does not seem to be a clear end to it. So we have to learn to live with it somehow. We also know that schools are essential for child health and well-being for a number of different reasons. And we know that when schools have tried to open without precautions, they have almost always failed, even when community transmission has been low. You may have heard about Israel's experience where they had very low transmission in the community when they opened schools, but as soon as schools opened, their numbers started to go up. So we have to somehow figure out a way to open schools safely. So what do we know about COVID-19 in children? So just very quickly, I wanted to touch base on this before we talk about the topic on transmission of SARS-CoV-2 by children. So we know that most children are asymptomatic or have very mild disease. In the US, there was a recent study that was just published a couple of weeks ago, looking at the rates of hospitalization for COVID-19 in children. It turns out there are about only 8 per 100,000 population of children require hospitalization. That is compared to 164.5 adults per 100,000 adults. However, when children are admitted into the hospital for COVID-19, almost 1 in 3 of them have required ICU level care. So in other words, not very many kids require hospitalization, but those that do tend to require higher level of care related to the COVID. The risk factors associated with severe disease are obesity, chronic lung disease, and this does not include asthma. This is more structural chronic lung disease. And prematurity, anyone who's less than 37 weeks gestation, and children who are less than 2 years of age. There was also a recent British study that looked at data from 260 hospitals in the UK. They showed that 35% of those children who were admitted were under 12 months of age. So again, that goes along with what we have noticed in the US as well, is that younger kids tend to require higher levels of care. That is only 1% of 627 patients in this cohort were patients who had died, and almost all of them had profound comorbidity. And then 11% met the WHO criteria for multi-system inflammatory syndrome in children. So again, this is the syndrome that we've noticed that is basically post-infectious and is may perhaps related to delayed immune reaction to COVID-19. So this graph on the left-hand side of the screen looks at the kinds of symptoms that these patients present with, and you'll notice that yellow means no. So a vast majority, many of these kids basically have no symptoms really. And the most common symptom is history of fever and cough, and then some nausea, some GI symptoms, and some respiratory symptoms as well. So there are lots and lots of unknowns about schools and about transmission from children, from adults. So the questions that have come up recently are, do children transmit virus to adults or to other children? We know that adults transmit to adults and adults transmit to children, but the other way has not really been studied very well. The early data that we do have in our experience as well showed that more than 90% of children who were COVID positive also had a family member who was positive at the time. But the caveat to all of this is that students studies that were done at that time were done in the setting of schools being closed. The schools were among the first to be closed during the pandemic. And so that data needs to be looked at in that context, that kids were really not getting out of the house. And so it makes sense that most of the children that we saw early on in this disease process were those that had a positive family member first. So the question is, will we see an increase in pediatric cases when schools open? I think some of the recent news articles that I showed you suggest that yes, we will. And then what happens, and what about an increased risk of teachers, parents, and other caregivers? And that's where the transmission, the transmission question comes in, because if children are getting infected but are not showing that many symptoms, what is their risk of transmitting it to their teachers, and what is their risk for bringing it home and transmitting it to the parents and other caregivers who are obviously adults and will be at higher risk for severe disease with COVID-19. The other question that comes up often is, will a pediatric vaccine against COVID-19 be available anytime soon? And the answer to that is, I don't think so, not as a peds ID physician. All right, so what is the data that we have right now? So one of the recent studies that has come out has been this South Korea contact tracing study that looked at children. They basically had a cohort of patients that were positive and then followed and saw how many of their contacts became positive. And so what you're seeing over here are household contacts and non-household contacts. And what's interesting to note is that when you look at household contacts, the positivity rate, so this is the positivity rate in their contact, so the contact of the person who was positive. So in the 0 to 9 age group, 5.3% of their contacts were positive, but in 10 to 19 year age group, 18.6% of their contacts were positive. And that is almost as high as the elderly age group, which we know these are the groups that carries a lot more virus and tend to get sicker. And so children 10 to 19 years of age had the highest rate of transmission to family members. It is important to note that the study was not looking at directionality of transmission. So it is totally possible that another family member was positive first, then gave it to this child, and the child was then the one that was detected and misunderstood as the index case. But either ways, it is really interesting to note that in that 10 to 19 years of age, their contacts had one of the highest positivity rates. And this is a study that was actually published by my colleagues at Lurie Children's Hospital. And this study looked at 145 patients that were admitted with mild to moderate illness in the hospital, and within 1 week of their symptom onset. So what we're looking at over here in this graph are the CT values. So remember, the CT values are basically the cycle threshold. So when you do a PCR, a lower cycle threshold means that you have that the patient or the patient sample has a much higher viral load, and the higher cycle threshold means that it takes more cycles of the PCR test to give a positive result. And so a lower cycle threshold essentially means higher viral load. And so what you're seeing over here is that in patients who have mild to moderate disease, children who are less than 5-year-old have a much lower threshold, cycle threshold, compared to those that are 5 to 17 years of age, or those that are adults and greater than 18 years. And again, so lower cycle threshold means that they have much higher viral loads. And so the observed difference in median CT values between children and adults is essentially translated to 10-fold to 100-fold greater amount of SARS-CoV-2 in their upper respiratory tract infection. Again, carrying higher loads of virus does not necessarily equate to transmission, but again, I think that this is important data to look at, and also goes to the fact that when we've talked about children getting infected, one of the earlier thoughts was maybe they just don't carry that much virus, but I think the reverse is true, that they actually do carry a large amount of viral load, but they probably don't react to it and don't get sick from that virus the same way that adults do. But because they carry much higher viral loads, there's also a higher risk of transmission by younger children. And then there was another study that is actually not published yet, but this is from my colleagues at Duke. I trained at Duke, so I know that this is good, solid science that they've presented. And so hopefully this will actually be peer reviewed and published soon as well. But this is a study that they looked at, essentially they followed a prospective cohort of children and adolescents who were less than 21 years of age. And they looked at SARS-CoV-2 infection in their close contact. So again, this is sort of a contact tracing, except that they actually did PCR testing of their contacts as well. And so what they found was that within close contacts of SARS-CoV-2, if the child had a sibling, they were much more likely to get infected than if the parent was initially infected, which kind of makes sense to me because we know that adults and parents are probably much better at keeping themselves away from children, whereas siblings, if anyone has children, I think it is very hard to keep siblings apart. So I think this sort of makes sense. And then the other interesting thing that they found out was that the children who did not get infected, they were less likely were more like, or I guess I should say, asthma was actually almost a protective factor. And so kids who had asthma were less likely to get infected with SARS-CoV-2 and have symptoms of SARS-CoV-2 than those that did not have asthma. And then there's another study that you guys may have seen, which recently came out. We're looking at the SARS-CoV-2 outbreak in overnight camp in Georgia. So this was a study that where they had basically this was an overnight camp. They had hundreds of kids over there and did not really take all that many precautions. And so again, in that earlier younger age group, 6 to 10, 11 to 17, there's a pretty significant attack rate. The attack rate again is the number of contacts that become positive with the SARS-CoV-2 after coming into contact with the infected patient. And then they also noted that at the different times during the camp, so for example, when only the trainees were there, when the staff members came, and when their campers came. So progressively, you can see that there was increasing numbers of patients, increasing number of people in the camp, and there was also increasing number of attack rates. And then they also looked at the cabin size. So when you had a smaller cabin size, meaning that there were only 1 to 3 people per cabin, the attack rate was much lower. When you had large cabin sizes, 16 to 26, which is essentially what a classroom looks like, the attack rate was almost 53%. So they, again, this camp did not take some of the common measurements that, precautionary measures that we have talked about. They did require all their campers and their trainees and staff members to provide documented negative viral SARS-CoV-2 test less than 12 days before arriving. And all the staff members were required to wear a cloth mask. And if they actually did, we don't really know. But again, because the testing was done prior to arriving and it was, within 12 days, it is possible that children could have, or those trainees or campers could have, in fact, gotten infected within those 12 days. And then other measures that they did not take were that kids did not wear cloth masks. Only the adult staff members were supposed to be wearing masks. They did not also open windows and doors, and were not careful about increased ventilation. And then they did a variety of activities that were both indoor and outdoor, but that included, vigorous singing and cheering, and we know things such as that do increase the risk of aerosolization of the virus and therefore spread to other people. So, not everything is doom and gloom. There was a recent study that also looked at a success story. So this was again, an overnight camp that looked at that was in Maine, in the US. And what they did was that before the camp, staff and campers were asked to quarantine with their family. So as opposed to getting tested before coming to this camp, they asked their family to basically quarantine at home, not meet anybody else for 10 to 14 days before coming. And then they were also required to provide a negative test for COVID-19 and were screened for symptoms. During the camp, the staff and campers were tested again, and then they were quarantined in smaller groups in the first 2 weeks. So they basically stuck with their own cohort of other campers and staff members during that time. Campers were encouraged to bring their own sporting equipment. Everyone wore facial coverings, so everybody has masks on. They all practiced physical distancing when around other people outside the group, and among other measures that they took. And then as a result of all of these, they did have some people who turned positive, but only 3 people ended up turning positive in that entire camp. And there was no other outbreak after, even after 6 to 8 weeks of camp. So what this really shows is that when you take the proper measures and you maintain a small cohort, even within a larger camp, and you are careful about symptom screening and about isolating as soon as symptoms occur or test is positive, there may not be any way to stop the infections from happening in children and in staffers, but there is a way to prevent the spread from happening to other uninfected people. So the big takeaways from the last 10 or 20 minutes that I've been talking are hopefully that children can get severely ill from COVID-19. I think we know that most of them will get mild disease, but there is a chance of them getting severely ill as well. Younger children may carry significantly more viral load than older children, though that, again, as I said, that does not necessarily mean transmission. And not surprisingly, this viral load is highest just before and after symptoms. The risk of infection is higher when a sibling is infected compared to parent. I think, to me, that also makes sense. And distancing, masking, ventilation, reduced class sizes are absolutely essential if schools are to be open safe. So with that, I'll end.
Thank you very much, Mehreen. This is an excellent summary of current state of knowledge. I'm going to ask Dr. Robin Sheikh now to comment from a school nurse's perspective on the measures that you were suggesting in your talk. What is the status in your school district?
So very interesting that you brought up Texas and Georgia, and I would just say that not all states are equal. Some states have been practicing with the consistent messaging of social distancing, hand washing, mandatory mask policies, quarantine policies, and also contact tracing. In the state of Massachusetts, we've been doing a lot of contact tracing, and when COVID began back in March, the school nurses in the state of Massachusetts got the charge from the public health nurses from local boards of health to start doing contact tracing. So we have already been working on making sure that our communities are at a low level of COVID. As far as my school, we have been working on different strategies to reduce class sizes. We're going to be going hybrid, which means that we're going to be doing some online and some in-school learning. class sizes are going to be smaller. And, ooh, hey, just a second. Something's happening with my computer, sorry. We're going to be practicing mask wearing, not practicing, we will be doing mask wearing. And also we've changed our hallways direction so that kids have an organized way of moving about the school. We have hired more staff to monitor the hallway so that there won't be those big bunches of students in the hallways at one time. And those are the things that we're working on.
So I think I'll ask this question to other panelists before, but being a little familiar with the Lincoln Sudbury School District, I know this is a fairly affluent area with a high tax rate. What's happening in other parts of Massachusetts that do not have as strong a tax base, or the school districts are not as wealthy to provide all these measures?
So we have about 32 states that, 32 towns that have decided to do completely online learning. So Boston Public is starting off doing completely online. Framingham is going to be doing completely online for the first few weeks. I think that a lot of schools want to see what other schools are doing to see if the rate is going to increase. And so it's hard to say what's going to happen. We just don't know. It's just not a lot of data out there.
Thank you, Robin. Dr. Asma Jaffrey, please, we'd love to hear your comments and any additional thought you have on this really important issue.
I guess I have a lot of questions and rather than comments, because as Dr. Arshad and Dr. Sheikh mentioned, there's a lot of unknowns to the science in terms of how it's going to work out, because when the pandemic started in March, a lot of schools closed down one after another. And so they were not part of the main risk of the main conduit for transmission in the community. My comments would relate to the fact that schools are not isolated institutions. They are part of the community. So a lot of what we have to look at is what's happening in the community. For example, in my state, California, in the Central Valley, in spite of having containment in the more of the, I would call them the coastal communities that are relatively affluent economically, the Central Valley draws from mostly farm workers, Hispanic populations, and the density of living at home and things like that precludes isolation even in the home environments. So when the state says you cannot open schools, basically the schooling at home also becomes a challenge in terms of internet access, computers, desks, and multiple siblings in the same room doing transmission. So I think what the pandemic has done is increase the divide between the privileged and not privileged communities in various states. And I don't think there's a easy fix to that, except that needs to be looked at for reopening of schools. And I know, at least in our state, there's look at opening just the elementary schools with more distancing and more spread of the students, because that will allow for the cognitive, emotional, social development of the kids, 5 and younger, or 5 to 6, and they seem to be the ones that transmit at lower rates than the older adults or the adolescents. So for California, at least the middle and high schools will remain online for this next semester, but there is landmarks we have to meet as a state, as a community, before you can open your elementary school. The other comment I have is, we should really look at outdoor schooling, and especially in Pakistan, I think, where the weather, if weather permits, and I remember when I was growing up that I would hear there would be schools where they under the tree, a teacher would gather students and do the teaching. So that allows for much less transmission, and kids enjoy it too. So I think that would be like opening your doors and windows, and also outdoors would be a definitely lower risk compared to indoor schooling. So thank you for asking.
Thank you very much, Dr. Jaffrey. Dr. Sami Ahmed, please, we'd love to hear your thoughts on this really important topic.
Yes, thank you so much. Thank you. So I think one thing we have to always keep in mind is that children go to school for not only their education, but they go to socialize, to have athletics. Many children get maybe 2 meals a day from their school. It also takes them away from a home which maybe doesn't have the most safest environment. So it actually protects them from abuse from within the home. And when you take that away at home, you have children, maybe they're very sedentary in front of electronics, they're not getting fed, higher chance of abuse within the home from parents or maybe some odds and end caregivers that might have to be called in. For the parents, school also acts as a childcare facility so that they can work or take care of other children or other responsibilities. So it's really a very all-encompassing environment for children. So when that is taken away, you see higher rates of anxiety, depression, ADHD, which cannot be managed. And again, exactly how somebody brought up, the disparity among households will really become apparent because the affluent family can afford maybe a private tutor or afford maybe a one parent to stay home. They can also obviously feed their children private, tennis lessons or something, which other families cannot. So it really deepens that divide. And not only the educational, you have some children having live stream schooling, you have others having pre-recorded lessons. So there's a very big difference in that. And then the other thing you see is that even within schools that open, like I live in Texas, and most recently they said in San Antonio, they said that you have to limit the cohort to only 6 children. Now, even for very well-off schools, you will see that some schools have larger campuses. Like Dr. Jaffrey said, they can have outdoor classrooms, whereas again, even affluent schools, they will have, some of them might have smaller classrooms in comparison. Then you compare that to a large public high school, which would be extremely hard to just have 6 children come in at once. And then you have the not so well off schools, which it would be extremely difficult. So just to put it together, I think like it's been said, younger children, they transmit less, they can with proper precautions go into school, but it's extremely difficult for everybody across the board to follow those precautions. So thank you very much.
Thank you, Dr. Sami Ahmed. So I think it's a very interesting challenge both for affluent communities and especially for school districts in the densely populated urban areas, which are already badly affected by community infection. I think at this point, I'd like to invite Dr. Ijaz Khan from Islamabad, Pakistan. He's very active in the Ministry of Health and the National Center for Disease Control. So let me ask him, what's the situation of schooling in Pakistan? And then we'll come back to, so I will, if you could please have your.
Thank you, Dr. Iqbal.
Thank you.
Assalamu alaikum and good morning in the US to all of you. Schools are going to open soon. That's what we are hearing. And by 15th of September, most probably they are going to open the schools, but the final decision will come in around 7th of September. At the moment, people that we see around, it's quite a sense of joy among the people, and very few are actually using masks for social distancing. So, and when you go around, we can see children without any mask roaming about. And schools in the posh areas, I think, in the big schools, they have the SOPs and they have already given the instructions how they are going to open and what will be the so-called SOPs or the process will work on. But we'll see how much they will be properly implemented. The schools in the rural areas, as Dr. Jaffrey was saying, in Sindh, Balochistan, KP, and in Punjab, the rural area schools are very airy. They are big classrooms, and there are schools which do not have any walls even, and where the children they sit under the trees and under the sun sometimes. So mostly, I think the vulnerable are the schools which are in the high societies, which are the big schools, 4 or 5 or 6 big chains of schools where the students from upper middle class or in upper class they go, and there we'll see how they manage it. But I think it would be important that there is continuous monitoring and the testing of the school staff. Perhaps after 15 days, because there were 4 or 5 points given by Dr. Mehreen, which I think they are important, and the testing of the school staff would be very much important, and parents must be very much cautious. Any one of them, if they feel that there are, and I think there are some help groups, self-help groups. They have the WhatsApp groups of the parents as well, now have been established, on which they are continuously in contact with one another, sharing the information. So I think it's mostly the awareness which is going to help the people, help the children as well. But we have to see, and I think one thing is this, that there is some evidence that as the temperature will go down, we'll start seeing cases go up. And I think very soon in northern Pakistan, 15 September and onwards, the temperature will go down rapidly up to 12 degrees centigrade or 10 degrees centigrade. So, and if the cases start coming up, and there will be some positive cases seen in the schools or staff or in the community, perhaps they will again go for the closure of the schools and back to the COVID style of schooling. Thank you.
Thank you, Dr. Jasab. I think one question for you I would have is, let's say, for example, in the United States, there are a lot of national level bodies, for example, the American Academy of Pediatrics, the Centers for Disease Control, who have laid out guidelines for school opening. And I think certainly the AAP, the American Academy of Pediatrics, their viewpoint is that they absolutely they are very pro school opening, because the benefits of children in school is multifactorial and really important for multiple reasons, as mentioned. Is there in Pakistan a national level or a federal or provincial guideline for school districts or individual private and public schools in terms of opening or reopening? Thank you.
Yes, they have given out the guideline. The Ministry of Education and Health and also the NCOC, they have given the clear guidelines how the schools are going to open. And the schools, they have also prepared by themselves, and Pakistan Pediatric Association, as well as the Pakistan Medical Association and Islamic Medical Association, PIMA, Pakistan Islamic Medical Association. There are certain medical associations and forums which are continuously discussing and given out some SOPs. And I think NCOC is the right forum to publish or distribute the SOPs for school opening. Government is working on that. I think there is a preliminary, for instance, the Higher Education Commission, they have already given and sent out their SOPs for how the classes will be conducted for the universities. So similarly, the Education Ministry, which is education is a devolved subject, as well as the health in Pakistan. So I think the education ministries in the provinces and the federal level, they have also developed their own standard operating procedures, and they have already distributed.
Thank you. Another question related to that would be that, when I was looking at the data from Pakistan recently about national levels of infection and provincial levels, I wasn't able to see the age distribution. What is the data on infection rate or positivity rate or mortality rates in children with COVID-19 in Pakistan?
Yes, you are right. We don't have that age segregated data. when it comes to children, like in the US and like in Korea and US, as presented by Dr. Mehreen. It is they have those age brackets where it becomes more infective, or which age group is transmitting the virus than the other one. But I think we still have to look at our data or analyze with that angle, whatever data we have. And I think they're working on that. Recently, they've done a zero prevalence survey as well, in which the 11% has come out, and it was just in the 20 districts. So I think still we are in the process of looking at the data with different aspects. But I think as soon as now this thing is building up for the school opening, perhaps very soon, the thing that you have said, people will start thinking that looking at different data sets with age brackets or age segregated data.
So I can tell you, I can share the experience of our school district and many others in Texas that have recently reopened, starting about 2 weeks ago. And in our town, a large school district, relatively affluent city, 55% of the parents actually chose, 55 to 60% chose in-person schooling, and 45% chose remote schooling. And of course, everybody has a laptop and computer and access. And the first morning on Monday, Zoom, which is the platform, went down for an hour nationally because of the load. So not necessarily remote learning has their own problems. And we've been seeing reports that there was a positive case in one of the middle schools, and that has thrown the school district into a flurry. One of the other issues about Texas, as Sami will share as well, is that current temperature right now is about 100 degrees Fahrenheit. So open air schooling is a little bit problematic. I mean, and parts of southern Pakistan, central Pakistan will have the same issue of very high temperatures in August. I'd like to get a few questions answered from some of our panelists, and Dr. Mariam Motin from California. She's a cardiologist and heads our cardiology section for APPNA MERIT. Asks if do schools in Pakistan have access to computers and internet? How will schools overcome the need for written assignment submission in areas that do not have access to outdoor or remote schooling? So that is one question. Dr. Jaz, would you be able to answer that?
Yeah, as far as the posh or affluent schools are concerned, they were having all their classes with the school with the students on daily basis, mostly on Zoom, and some of them they were using the Google Classroom. And of course, the same problem the parents experienced there. All of my 4 children, they are up at 8 a.m. till 2 p.m. and our internet has a lot of issues. It goes down, and then we have to use other alternate companies' internet as well to keep it up. So this is the problem everywhere. For the schools which are the remote and they don't have the facility. The thing is this, that the internet is present in Pakistan in almost all cities, but if you talk about remote Balochistan, remote KP areas or FATA areas, and some of the district, Sindh district, which are adjacent to Balochistan, perhaps there will be some problems. But you know, in Pakistan, we have 2 different type of school systems, or 2 different type of education. One is for the affluent class, and other is for the general, the public sector schooling. Now, public sector schooling is underfunded and perhaps undermanned as well. The issues of human resources also there. But most of the time, these schools have been closed, and the students, I know from one person who lives in Charsada in KP, and he works over here in Islamabad, and he told me that because the schools were closed, so he has called upon his son to do some skill work with him because schools were closed. So that means that in the public sector schools in the remote areas of Pakistan, they do not have the access to computer labs or computers, or just like in the cities. So in the remote areas, in smaller towns, it will be difficult to continue with the remote schooling, and perhaps the in-person schooling would be necessary, and more precautions and more measures would be required against COVID-19 spread.
Thank you. I'd like to ask a question of Dr. Mehreen Arshad. Is there a community percentage or infectivity rate that can be used as a guide for in-person school opening? I think one of this has been raised that as Dr. Asthma as well, and that really the risk depends on what the community level of infection is. So is there a community percentage or infection rate that you could say, yes, if it's lower than this, then in-person school opening would be much safer?
Yes, people have talked about positivity rates, so the number of tests that are positive of all the tests that are done, and positivity rate of less than 5% seems to be a safe enough number, or community transmission is low enough in that setting that school opening is probably safe. However, I will say that schools have opened in areas that with slightly higher positivity rates as well, and have done okay with measures in place. So I think that it's really important. So I think if hospitals are in places like Florida, where if your community has such high prevalence that hospitals are filled with patients, and there just makes no sense to open schools at that point. But if there is decreasing prevalence of the virus in the community, and 5% positivity rate is often quoted, but I don't know that there's real data to backing the fact that that higher numbers will not work. So I think in other words, I think you really have to look at the rate of transmission that is in the community, whether it's going up or it's stable or going down. Obviously, if it's going down, it's better. And then also the very important thing is to look at the precautions that are taken when schools open.
Thank you. I do have one more question before and that is, you mentioned of the risk factors in many studies. Ethnicity, for example, Black and Asian children in the UK, and obesity and asthma have been. Now, when you mentioned the data on asthma, it seemed to be a little counterintuitive to me, because I thought it was a risk factor, but what you said was that asthma is somehow protective from infection, or what's the situation?
Yeah, so the one study that looked at this that is actually not peer reviewed yet, they did notice that asthma might be protective. I think it may have to do with the fact that a lot of kids with asthma will use oral, inhaled steroids, for example, which may decrease their symptomatology, for example. But in our practice, I will say asthma has not come out to be a major risk factor. Chronic lung disease, which is different, which would be patients with, either prematurity or extended lung disease from that, or cystic fibrosis, that's a different thing. But asthma itself, we have not seen many kids with asthma have COVID-19. So again, the one study that I quoted that looked at it as a protective factor was there, but again, there's small numbers, one institution. So that's the state of the data that we have in pediatrics right now. So it's really hard to make judgment calls based on that. I think anybody who has asthma, who has any other chronic illness, needs to be extra careful in these circumstances, and needs to make sure that they themselves are wearing masks appropriately, and the schools and gatherings that they go into, everybody else is also wearing a mask.
Thank you very much. And this is for Dr. Robin Sheikh. how are you going to handle contact sports in your
So
area?
just quickly about asthma, just in terms of how we're going to be treating students with asthma, nebulizing treatments will not be part of something that we can do in school just because it becomes an aerosol. So making sure that students have their asthma action plans as they walk in school with with their steroids, of which they're going to be using as their first choice, would be really important to have kids up to date on that. We have not decided completely what we're doing with sports. I'm not part of that conversation, so sorry, I can't really answer that question. I know that they have been doing some captain trainings, which are not related to our school. And I know that some towns are going to be doing sports, and there are going to be some sports that are going to be okay to do. I know golf is a great sport that people are participating in, but there will be some sports that just won't be able to be part of the school system.
I can say a few words about that as well, Dr. Bal. So there are some gradations to how risky playing a sport is. So, for example, in Illinois, what they've done is now I think all schools. School level sports have been closed down, but initially what the thought had been, and that's again in Illinois because our numbers are increasing, so I think that was an appropriate decision made by the state government. But there are certain sports, for example, football, which is a contact sport, so not soccer, but football. So football is a contact sport because people are literally their whole job is to stop somebody else from getting the ball, right? So that is very high level, high risk of infection. There are other sports such as basketball that are middle, that are have a mid-risk, and then there are others that are like tennis, for example, golf, such as Robin mentioned. Those are sports where people have to stay apart in order to play the game. And so not all games should be banned, but I think we really need to look at the kind of sport that it is, and base our and sort of make a decision based on that.
So what about the Pakistani national sports of cricket and gully danda?
Well, I will say in cricket, people stay apart, so and it's played outdoors. So it's probably not, that hard. It's probably not that high risk. Gully danda, I'm not so sure. It's probably okay too.
Okay, so we'll advise not playing kabaddi in Pakistan, but it was a lot of fun. So one more question was about exposure. So let's say that we know that children are less likely to suffer from COVID-19 even if infected. In fact, in the study that the multiple study, for hospital admitted children, the mortality is less than 1%. In our institution, we have after about 16,000 people tested among the patients visiting Children's Health Network in Texas, there have been about 967 positive patients, and out of them, the highest number of admitted patients in the hospital was 22, out of which about 10 were in the ICU. We did have one patient who did not survive, but they had multiple risk factors. So we also had one patient who actually was discharged of the hospital after severe COVID pneumonia and being placed on ECMO. So overall, the risk to the individual child seems to be very low based upon what you've presented. But what is the risk of in large extended family living situations where there are elderly grandparents living in the same household and the children are going to school, perhaps picking up the infection, coming home? What should be the advice to those families? And I think that there's a lot of families in Pakistan, maybe the majority. And this is open to all members of the panel.
I can start, but yeah, I would love to hear other people's advice as well. It is really hard. And I think that's something, Dr. Asma, you probably would agree. This is something that we're seeing in the US as well, especially like Hispanic families. There are large extended families that live together, African-American families as well. So we've seen this in Chicago where a lot of times, there is not so much in kids because school is still closed, but young adults who are going out of the house to get to either to work or to socialize, or then bringing it back and infecting their elderly parents or their grandparents. And so that's one of the biggest challenges of dealing with school opening, is that you're not just looking at the infections and the symptoms that children will have, but what is going to happen to their elderly teachers, to their parents, to their grandparents who are all living together. I think that's the simple and unfortunately the realistic answer is that we will see an increase in those cases as well. And especially as I pointed out, that children who are 10 to 19 years old, so less than 10-year-old kids probably don't transmit the virus as well as adults do, but those who are 10 to 19 years old do transmit, and maybe transmit better than adults do. And this is also, I'm sort of looking at the chat right now. The teenagers are very hard to explain to them to stay away, wear masks, and that. So they are higher risk for multiple different reasons. Because of that. And so what we have been suggesting is that, and I think so right now, we've been suggesting this when a patient tests positive, a young child tests positive, and or they have symptoms, is that only the younger adults in the household take care of those children, and all the elderly either physically separate themselves out in another room if possible, or make sure that they are wearing masks and doing good hand hygiene when they're handling the children. The children should also wear a mask when they're coming into contact with their grandparents, for example. But I will tell you, this is very hard to do in many different, within families. And I think we just need to get the message out there that if we are going to keep our community rates down because of, related to school opening, we have to make sure that, we isolate children as soon as possible. When they have any sort of symptoms that might be upper respiratory infection-like symptoms, and that we keep the elderly population away from the children. But it's going to be hard irrespective.
I would agree with Dr. Arshad in terms of the extended family, multi-generational families. And that seems to be probably in Pakistan, it's a cultural component to having multi-generational families living together. And that's what we see in California, is mostly the Hispanics and African-American families, where it's much higher. And another factor is the transmission also depends on from the kids to the parents to the grandparents, and the sequelae is for the grandparents that have the risk of actually dying from the illness. So it's not just you're looking at the kid in isolation, you're looking at the whole family.
Yes, I just wanted to add that that's exactly my thoughts, as Dr. Jaffrey and Dr. Arshad said. I think one thing maybe we didn't mention is, like, with school opening, there's a couple other factors we have to look at, and that's as a community, what is their hospital capacity? What is their ICU capacity? So you have to take that into account as well, because some of these things will happen. They will transmit to people who are more vulnerable in their families, and then there has to be a capacity available to take care of those individuals. So that's one other thing we have to think about. And I also wanted to point out, this goes back a couple of questions back to Dr. Mariam's question and what Dr. Ejaz was answering about in Pakistan, how children, some of them will not be able to have internet access, and they might be doing unskilled work to help their parents out. So I think because these are unprecedented times, we have to think of really creative ways how to overcome this. Now, whether it is like, if they don't have internet, relying to radio education, something generic, a lesson that maybe all the children on the street or in that neighborhood can listen to on the radio. Whether they can do, like in college in Pakistan, we do a lot of like oral exams, but vivas over the telephone. I know my children, when they started school online, they had to sign an honor code. I mean, this has to bring out the best in people. But also maybe they have to turn in weekly handwritten assignments. End of the week, somebody mails it in or carries it and delivers it to a safe spot in the school. So really creative ways in how we will continue to educate children, those who are privileged and those who are not unprivileged, and when you cannot have outdoor education because of weather circumstances or space limitations.
Thank you very much. I think using mass media like radio and perhaps television is a great solution for low penetration of internet. So, obviously all of those things. Another question was, and this is to the panel, is information regarding transmission of COVID-19 in mosques and markets in Pakistan. Can these findings be applicable to schools in Pakistan? So I think, it's open to the panel, and we'll probably also ask Dr. Ijaz to shed some light on that. So please feel free to answer.
I can just comment. This is Asma Jaffrey from what I saw on television relating to how when the quarantine was lifted before the first Eid in May, and how the community transmission rate increased, and they had to reimpose the quarantine to get a handle on the transmission. I think a lot depends on the level of acceptance of the population, because if they don't believe, like there's cohorts like that in America that don't believe in COVID transmission, including our presidents in the early days mentioned that it's a hoax. So I think that education is the key forum, and any channels of community education should be utilized, including the mosques. That's part of their job. I believe that to prevent catastrophe in the community, they should be used as community education centers besides the prayer offerings, which they do.
Yes, I think very good points. It's almost as though we need to address this as a whole society. Definitely do all the distancing measures, but this is the time for where maybe a lot of entrepreneurial people can come up with solutions. Some of the things that are more common here, curbside pickup of groceries rather than going into small crowded shops, online shopping. I know it's harder again with internet issues, but also some cultures they like to go daily to buy milk and bread, but more of maybe like a wholesale shopping, so that you decrease the number of times you go out, thereby decreasing the number of shoppers in a market. Our mosque, we did a Facebook Live Taraweeh during Ramadan, prayers. I know some people don't find it that to be as optimal. So just maybe different means of it. Having proper distancing in mosques, or maybe having it outdoor worship for worshipers if they do like.
Yeah, I think I agree with all the other panelists. It's, mosques are, so first of all, I have not seen a specific study that has come out of mosques, but I think there is some experience with it. But if there is one, I'd love to see one. But I think the other thing is, in the US, they've had, at least in our school district, we've started to make these internet hotspots. So in the community centers, the internet has basically been opened to anyone. So anyone who goes into the community center, sits outside the community center, is able to log in and check their email or whatever. So perhaps that may be one one useful thing to look at for mosques in Pakistan, because rather than giving internet to every single individual household, which would be more expensive and probably not very feasible in far-flung areas, perhaps mosques can get that internet hotspot and have students. And again, mosques are generally open, they're larger spaces. There's probably more ability for students and patients and adults and children to socially distance themselves. So I think mosque space can be used creatively to help this problem in other especially in terms of the internet and online access.
Thank you. And there's another question about, is there a difference in response and acceptance to COVID-19 precautions in primary schools, secondary schools, and colleges?
So I think that So, there are countries and communities that have opened their elementary school first and have actually done that fairly successfully. I think what we do know is that children, and I think we actually have, I think Dr. Asma was pointing out that daycares remained open in many of the larger cities for essential care workers and did not have the large outbreaks that we're seeing with school opening. And so I think that younger population, the 0 to 10 year or 0 to 9 year of age, actually does fairly well. They don't get sick too much themselves. They're not good, efficient transmitters of the virus. And so I think opening elementary schools is probably, as a first step, if we talk about tiered opening of schools, is probably a good idea. The other thing is that this age group needs a lot more supervision to do their schoolwork. Whereas middle school and high school children are anybody who has kids will agree that this is the age group that doesn't listen. You can tell them all you want to put their masks on, but they love to socialize. They want their friends. But they're also the group that doesn't listen very well. And so, we have seen that community outbreaks, especially in schools, have happened in middle and higher schools and high schools, and also in college settings where young adults, tend to socialize a lot and they're, don't maintain a lot of social distance. And these age groups tend to, more than greater than 21 are also that age where they can do homework or should be able to do schoolwork unsupervised as much. And so I think that if in an ideal world, if I was opening schools, I would open elementary schools first and see how things go, make sure that all the SOPs are followed, and then slowly open up the rest of the schools while maintaining a virtual school option for the higher schools as well.
Thank you. And, there's some very interesting comments by Dr. Jaz Khan and others in the chat group. Talking about the teenagers are the biggest violators for social distancing in the United States. And that's, Dr. Khan said, same here, but our teenage extends to 60 years plus. And then the good news is that Pakistan television has already launched a channel from prep to 10th grade. So that's very positive. And as Dr. Asma Jafri has mentioned that the collective shopping is a little problematic for daily wage earners. They need to get their groceries daily. And online textbooks or purchased by a university, it is costly. I think the problem with online textbooks in Pakistan, again, is the penetration and availability of internet. There is one question I had for Dr. Khan, Dr. Jaz Khan from Pakistan is, and this has been mentioned in the news, and I don't know how correct this is. Pakistan has been lauded for the mysterious lower rate of infectivity and morbidity and mortality for a country of 220 million. One of the critiques has been that not enough people were tested. But when I've asked people in the know, they said, well, you cannot really hide deaths, increased number of deaths in the country. So Dr. Jaz, what is really happening and what is the percentage of community positivity rate in Pakistan in Europe?
Yes, actually, I had this. I was given an opportunity by APPNA MERIT to present my modeling, which my team and I did during May this year, and those estimates, those were just estimates. They cannot give the correct figures of mortality, but a near to truth kind of morbidity of the cases could be given. What we could bring in, if we could see that the peak was around June 21, and whatever testing we were doing, around 25,000 cases, 25,000 per day, we saw a kind of peak around June 20. And then our model, it showed that it will dwindle off by last week of August or first week of September, we will have the least number of cases and least number of deaths. So actually, how much the tip of the iceberg we are looking at through our limited testing, the trend is the same. So it followed the trend, and it was a scenario in which if you do an intervention or not, there was a very little impact of intervention, and it would have followed its own course of epidemic curve for Pakistan. And for Pakistan, luckily, it followed its epidemic curve. For other countries, for instance, if you look at India, it didn't follow. It had more than 60,000 deaths by now, and it's a problem. But the countries like the Middle Eastern countries, then you don't hear much from Afghanistan, for Sri Lanka, Bangladesh, some other countries as well. There have been not much mortality or much cases. So the virus has been behaving very, very strangely. I think it had some mutations. Perhaps I think it would be important or interesting to look into or look at its mutations, because it has mutated recently. It was found mutated in Korea, then in Malaysia, then in the US, and then perhaps, and we haven't done in Pakistan, we haven't done its testing on and look at its genome, whether it has mutated in Pakistan or not. But once it mutates, it loses its infectivity, and you can say that it becomes less lethal before it again cycles up to become more lethal. So it's a strange kind of behavior of this virus. In Pakistan, it has followed the epidemic curve, what we did or other researchers also did, and luckily it was not that much. But the one point is that also comes into my mind, because we didn't test each death which have been happening in the community for COVID. So not all for instance, not all the patients which die of heart attack, they reach hospitals in Pakistan. It's not like US that every patient has an opportunity to reach a hospital. So many, they die at home or at other places. So, and we never tested them whether those deaths were, because most of there were deaths due to the respiratory issues for the COPD patients, but they went into respiratory distress, and they required oxygen or ventilation at the end. But there were many patients which had if you look at the epidemiology of disease in Pakistan, so around 28% of Pakistanis, they are diabetic. Around 50%, one of the Pakistani surveys, it showed is almost 50% or to be precise, around 46% of Pakistanis, they are hypertensive. And the major cause of death among the young people age 31 to around 29 to 39 or 41 years of age is due to the myocardial infarction. So these people who died, or perhaps they were not diagnosed, because you see in Pakistan, the major issue, there is another issue that we don't have the reporting by cause of death. In the US, in the UK and other countries, you always get ICD-10 or ICD-11 classification for death, and death is registered. So in Pakistan, it is not like this. So it of course for COVID, it was not registered. It has been like there were the cases who were diagnosed as COVID, and later on they were admitted to the hospital and they died of COVID. They died of COVID. But if someone came with acute MI in emergency and he was tried to resuscitate, but he passed away. So people never like to be we have our cultural issues as well. So they don't like the body to be touched. And you see in the beginning, there was a lot of fear. If somebody was diagnosed from if someone was PCR positive for COVID, so he was immediately there was a kind of police used to come to the house, and the person was isolated forcibly and was taken away. And there were a lot of social issues. And after that, I think it also started coming up that people stopped going for testing. If they had some symptoms, they prefer to stay home, isolate by themselves, or take remedies and take some medicine or something like that, or consult their GPs by themselves on phones and start doing the measure by themselves. So that's why we don't have so many. That can be one reason that we don't have so many registered positive cases and deaths as well. But whatever the scenario has been, at the moment, the positivity rate is around 1.8%. So it has gone down. Whatever the testing we are doing, so we're just having a sample, and it shows that it's around 1.8%. It's going down. So it is very encouraging. Fear is this, that as soon as the temperature will go down and the people who have stopped using all the measures and they have become very relaxed, that might result into another peak or the second wave at the start of the winter, around end of October or mid of November. And one study that is yet to be published, but it was done in China. I had an opportunity to look at it just off the record. It analyzed the COVID outbreak in China, and for every 1 degree centigrade rise in temperature, there was a less risk of 12.5% less risk of dying of COVID. So that is one thing. And another thing is this, that the trend is a bit different for summer region than from the winter region. For summer, the peak comes slowly, but it goes down quickly. But for winter, the trend is like this, that peak comes very rapidly, but it goes off very slowly. So that means if the peak comes in around by mid-November, the second waves come around mid-November, and no measures are in place, and people are very relaxed, just like in New Zealand, they immediately took the measures. But if in Pakistan, people don't care, they don't take measures. So that peak is going to come very quickly, very sharply. A lot of cases, lot of numbers of cases with mortality as well. And then it will linger on for 2 or 3 or 4 months, maybe up to March or April. So then the burden on the hospitals will be extreme and massive. So this is one thing at which my team and we are also looking at the moment for Pakistan scenario, and hopefully we'll come up with something which could guide for decision makers. Thank you.
Thank you very much for that very detailed analysis. I think there was several questions, and we are really kind of a little bit over our time, but I think I'd like to, I think you addressed the temperature issue to some degree. And one of the questions is that, does the virus die at 56 degrees? That's a very high temperature, so 126 degrees. I know that parts of Pakistan get there. But is there a certain temperature and environmental temperature at which the viral transmission is reduced to nearly zero? Any, Dr. Mehreen?
No, there isn't. But there is, the coronavirus itself is actually a pretty wimpy virus. It doesn't last very long on surfaces, you know, so higher temperatures, you know, humidity. That all of those are factors that do help in reducing its the amount of virus in the environment. And I think that is also goes in line with what we've noticed, is that fomites or surfaces are not a very good you know, mode of transmission of this virus. So most of the virus is spread by aerosols or droplets, and so it doesn't survive very well in the environment. And I think the difference between summer and winter probably has more to do with how people congregate in spaces during the two different seasons. And so in winters, people tend to stay indoors more, you know, and so they're coming into contact with other household members, or, you know, if they're working, then they're coming into contact with other co-workers more readily because of the colder temperatures outside. So that probably has more to do with it rather than the environmental temperature.
Thank you. I think there's a lot of suggested explanations for Pakistan's somewhat successful drop in viral cases, having houses which are not air conditioned and generally have open windows is being suggested, as well as the immunization panel that all children receive in South Asia. So any final thoughts on any of these? And then I have a question, which is, as Dr. Ijaz Khan mentioned, that at least the estimated positivity rate is 1.8%. So that would be in line with a low community level, and would suggest that school opening in person is relatively safe compared to places like Florida, California, and Texas, certainly. So would you agree with that?
I think so. I think Pakistan is in a kind of a sweet spot right now where, school openings are probably safe. I would still say that I think opening them without proper precautions is probably not a good idea. And I think the SOPs that are being developed, I know by the government, and I've seen the ones that were put out by the Sindh government recently. They're pretty good. I think they're sort of along the lines that what we've been talking about in the US. And so the key would be to implement those SOPs and make sure that people are following them. The other thing I just wanted to also point out is that I think one of the worries that we have in the US, at least, is that as winter comes, we know that other respiratory viruses will also increase. And so we have seen earlier on in the pandemic, we did see a lot of co-infection, especially in children, where children were being positive, were COVID positive, but also had flu or RSV. And so the worry that we have as pediatric ID people is that we are going to start seeing multiple different infections and co-infections in children, which may worsen their outcomes. And so, we know that flu does cause severe disease in children, especially those that are unimmunized. And so we're just worrying that, with COVID, this is going to just exponentially increase our numbers. And I think along those lines, I'm not sure what the state of flu vaccination for the general population is in Pakistan. I know that elderly tend to get it and can get it, but I think that's maybe one other thing that the health department in Pakistan probably need to look into, is to get more flu vaccines for the country in order to at least prevent the flu from spreading, so that we can, if there is an increase in COVID, as Dr. Ijaz mentioned, that we can, potentially at least, not have flu as a comorbidity or co-infection at the same time.
A lot of great ideas. I think Dr. Robin Sheikh has shared the Massachusetts risk color code, which is 8 per 100,000 is red, yellow is 4 to 8 per 100,000, white is less than or below 4 is green, and 5 total cases over 14-day period is white. So I think kind of community band of infectivity may guide school. And I think one of the questions, last question probably, is to the panelists before we should close out, is let's say that you do open schools and you do take all these measures, and then you have a rise in cases in your schools or in your school system or your community. And I'll start with Dr. Robin Sheikh. What do you do then? Do you close everything down, or what do you do with the contact tracing?
So I hope that all schools have a school nurse, and I know that that's something that Pakistan needs to start thinking about considering, to start getting a workforce of school nurses, because we're the primary care, but we're also the people who are going to be doing surveillance on COVID in the school systems. It really depends if we're going to close school on how many cases. I'm pretty sure that my school will probably close school for a couple of days if there's a positive case. But not all schools will do that. This color coding that you just went through, white, fewer than 5 total cases over a 14-day period, that's kind of a go in other states and other towns. So each town is going to be different. And I think the most difficult part is the asymptomatic kids that are going to be in the school system that we just don't know who's contagious and who's not. And that's going to be the most difficult part. And as a school nurse assessing, is this an anaphylactic reaction that a student is vomiting, or is this COVID? making that distinction with kids coming in, I mean, it's going to be very difficult.
Yeah, I agree with you. I think that it is going to be a very, very hard, I mean, for pediatricians, for school nurses, this is distinguishing COVID from all the other things that kids can get is going to be very hard. I do think that this concept of cohorting, of having students that are in a cohort and not interacting with other cohorts on playgrounds or, during lunchtime and stuff like that. I think that really does help, because what that allows, if done properly, what that allows us to do is to quarantine the cohort and not close down the entire school. But again, it has to be done appropriately. It has to be done strictly. And everybody, and there needs to be a buy-in from both the students, the parents, as well as the teachers and the administration of the school in order to make that happen. But the way cohort, theoretically, if done appropriately, cohorting will allow schools to continue to remain open without, even if there are cases within their school. But the cohort in which the positive case happens, that only that needs to be quarantined.
I would also add that not every school has a school nurse. In the state of Florida, it's like one nurse per 2,600 kids. So, I mean, really, you want to have one school nurse per 500 kids. And so without having that proper surveillance, it's going to be very difficult for schools to come up with a plan.
I just wanted to add that some experts who have studied pandemics over the years have the cohort idea is, I think, very, very, it's an excellent idea, and I hope that works. Some of the information that's come out of experts in pandemics have said that over history, what happens is that there's the hammer and the dance. So you stamp it out, everything is shut down to below a critical level, and then you open it up, and then we know there will be a rise in cases, and then once you reach that threshold that you cannot remain open anymore, you have to shut everything down again and get below that critical number. And then again, you might have to open. So I think as Dr. Arshad said earlier, that COVID is as far as COVID-19 is here to stay for a while. So we may go through this hammer and dance phase where you open, shut down, open, shut down.
Dr. Asma Jaffrey.
Sorry, I think it's a good idea to have cohort management, but I think that also depends on keeping whereabouts of your kids at all times. And again, as I mentioned, sometimes the transmission is not from a colleague student, and it could be from other activities in the community. So that's where the link, I think the idea of your baseline community rates as a metric to allow for school opening is a good point, because then your risk is low because your community rates are low. And again, isolation just for schools is a good measure to look at. But again, I think the kids are not, they're social beings just like us adults, and they like to meet parents, grandparents, friends in cohorts, whatever, after school. Because I think as some of the other panelists mentioned, the social isolation is the risk of not having schools open. And apparently there have been increased rates of depression and suicide in this pandemic. So I think that has to be looked at too. What is more riskier? Thank you.
Thank you very much. And of course, there are a lot of economic impacts of one or two parents not being able to work because of having kids out of school. We haven't talked about that, but I think Dr. Ijaz mentions in the chat that school nurses for surveillance of COVID is a great idea. And in Pakistan, schools plan to work in small shifts with no sports activity. So I think that's a great start. We're very happy to hear that things are getting better in Pakistan. A lot of great ideas came out of this panel and from the attendees and participants. So hopefully we'll have that, save that chat and those ideas for share it with Dr. Ijaz Khan and other colleagues in Pakistan. At this point, I want to thank our panelists, Dr. Mehreen Arshad, Dr. Asma Jafri, Dr. Sami Ahmed, and Dr. Robin Sheikh, and especially Dr. Jaz Khan, who joined us from Pakistan with his insights, and a lot of attendees who were very engaged, Dr. Mariam from California and Dr. Nigat as well. So thank you very much. We will hopefully meet again in this forum or in another. And good luck to everybody and stay safe. Assalamu alaikum.
Thank you.
Thank you very much. Thank you. Assalamu alaikum.
Very much, everybody. Thank you. Jazakallah khair.